Hello and welcome to Facebook Live here at CGH Medical Center. I'm Dr. Bill Bird, Chief Medical Officer here at CGH, and thank you so much for listening in. Looking forward to my guest today, Dr. Eric Coons, and I'll introduce him in just a minute here in more detail. But before I pull Dr. Coons on to have a conversation with him, I just wanted to share a couple of numbers, in particular about our vaccines and where we're at with those. So I have that as of today, this week, we will have given, let's see here. Yeah, so this upcoming this week, we have given, I think, 492 second dose vaccines. And where do I have it on my list? And I think, um, where's that at? Yeah, and then by the end of the week, we'll have given out 2,061 first dose vaccines since this all started. And 1,100 will receive both doses. And I'm pretty sure that's what we're talking about, the general public rather than our CGH folks. So things are starting to pick up. We're looking next week. We're looking. Matter of fact, if I remember right, I think this Saturday we might be doing 400 people for a clinic here at the hospital. So as we have vaccine available, we're giving it out. I just want to share with everyone. Seems to be getting a little more availability. We still have, though, on the 65 plus category list, I think we have still about 4,000 folks who are on that wait list. So it's still a ways to go before we get all those people taken care of. You may have, if you're 16 to 64 and have a risk factor, you may have received it. You probably will receive a text and or phone call pretty soon if you haven't already, because we're starting to send those out to folks. We did have a little glitch and sent out some of those to people who didn't have a complicating condition. I received one, and I was like, hey, I don't think I have that. So there was a number of people that happened the first time we sent that out, but we're letting those folks know. Just know that we're beginning to go down to the next list, so we're prepared if we get an onslaught of vaccines that we can give for that 16 to 64 group who have a qualifying medical condition. Okay, so let's bring Dr. Coons in. So, hi, Eric. How are you?
Yep. Good afternoon.
Good. Glad you could join me. So, just for people to recap, Dr. Coons is the department chair for Department of Medicine here at the hospital, and he also chairs our COVID clinical guidance team that kind of gives information to the rest of our medical staff about what's the latest and greatest with COVID and how to take care of treating that. And Dr. Coons does a really nice job on Facebook of every week or so posting information about what he's thinking about, what he's learning about COVID during this year. And because it's been about a year since this all kicked off, and we really have had to deal with that here in our community, I thought it'd be a good time to pull Dr. Coons back in to ask him some questions. So thank you for joining me.
Yeah, thanks. I was looking yesterday. It was March 15th, so almost exactly a year ago that you gave me a call when I was out at my last restaurant excursion at Flinny's in Dixon to say, oh, we have our first case. We we're on, so to speak, and it's all gone from there. So yeah, it's been a whirlwind year for sure.
It has been. Okay, so you ready to answer a few questions of mine and then others for those in the Facebook community as we start talking?
Yep.
All right, here goes. So first question, what have we learned about preventing COVID in the past year, Eric?
Yeah, well, there's been a lot of evolution. In the beginning, we were very worried about what we call fomites, things that can carry COVID on them, UPS packages and all those sort of things. And it's turned out that's been much less of an issue. It's not zero, but this concept of a viral load, how much virus it takes to get somebody infected, has become really important. And it's probably hard to get enough viral load in most situations from fomites. So that's been less of a focus. And it's important because we were a little worried about things like, could you get infected because you're touching your mask? And while that's possible, it turns out that's much less of a concern than we worried about in the beginning. And it's the airborne spread that really drives this. So that's where masks really come in helpful. And we can get into more detail on that later, but basically a really good fitting mask. And if you're in high risk situations, a better mask. You fit your amount of safety to the situation that you're in. And then the other thing that's really been interesting in terms of preventing COVID is we've learned that COVID really, it's what, medically speaking, what we call over dispersed, meaning that a few people cause a lot of disease, and there are a lot of people that don't cause much of any disease at all. And it makes it really confusing because certain people are like, well, I must be immune because I was next to this person for a long time when I didn't get it. Or, how did this one person infect all of these people? So COVID, about 30% of people seem to cause a vast majority of the illness, the so-called super spreader type of people, and that may be due to their high viral loads. It seems like older people are a little bit more likely to do that, and other factors, maybe even including just how loud or how much the people talk or all that sort of stuff. We don't know for sure all of those details, but certain people seem to be much more common to do that. And that really makes a difference in terms of how we manage risk. It makes bigger groups much more risky because you're taking a bigger risk. You're going to have one of those people in there. So if you have a super spreader in a group of 2 people, you can only get 2 people, one other person sick. And your risk of that person being that super spreader is less. But if you have a group of 30 or 40 people, now the likelihood that you have a super spreader starts to become very high. And if there's one there, they're going to get a lot of people sick. So that's why big groups tend to be still a significant risk. So those are the things the kind of pearls about what we've learned about preventing it. Of course, we're all familiar with it's still a good idea to wash your hands. It's a very good idea to wear a mask in the right situation. And all those things that we know about, but those were the 2 interesting things that have really evolved and we've learned better.
Yeah. Well, I remember when we were talking about, Eric, when this all started, there was I remember part of it was we just didn't have a lot of masks, but there was also this sense of, well, if you wear the mask wrong, it's worse than if you so that's definitely evolved over the last year.
Yeah, it's very clear that almost any mask is better than none. It is also clear that wearing your mask well, fitting it well is important too. But yeah, I think the days of saying that masks have any significant risk of harming people are no longer reasonable.
Yeah. What questions do we still have? Oh, here we go. Let's see. Because of the most public doing the masking and social distancing thing, has there been a noticeable decrease in cases of flu? And then would it then follow that people should continue masking and social distancing throughout future flu seasons?
Yeah, well, flu has been decimated. And I know this is kind of a spike conspiracy theories that we're just lumping influenza into COVID. And I get where that perception could come from. But one thing we're doing this year that we haven't before is we're testing everybody who comes into the hospital for COVID, influenza, and I think RSV.
Right.
So it's not that we're not looking, we're really not seeing it. I haven't seen a case of influenza this year, 0, period. And I saw an article recently that this year there has been 1 pediatric death from influenza across the country, and there was 150 some last year. So it really is different, and we're not alone. Australia similarly had a really low. So the lack of international travel, closing schools, masking, social distancing, they're really effective against the flu. And they're they're definitely helpful for COVID, but COVID's a lot harder. So as far as flu, we really just haven't seen much. And it's been an interesting lesson about how much control we do have over some of those things and some of the lessons that we'll take forward. So to their point, do we need to social distance and mask in the future? Boy, that's a big question about how far we go with that. But I think that in high risk situations, if we're in the middle of a flu outbreak next year, I would imagine you're going to see a lot of people wearing masks around, and I think we may well in the hospital as well. I mean, it's a little hard to prognosticate, but we've at least seen that that's effective. Whether it's worth the pain of doing so in all situations or in which situations, we can debate. But yeah, I think to the extent that if it's really active in the community at that moment, we may think about doing more of those things on a personal basis. I want to. I don't want to spread the idea that we're going to go into lockdown every flu season. That's probably not happening.
Right,
but,
right.
Yeah.
Yeah, good point. So, what would you say that we've learned about treating COVID? Oh, hold a second. Let's see what Mike has to say. I've been COVID symptom-free for 3 weeks. I've seen estimates that I should be immune for at least another month. Even if I did catch it again, shouldn't I have even less severe reaction the first time around, which was not bad.
Yeah, well, hello, Mike, coming from Arizona. He's my brother-in-law, so
Oh.
We have a wide audience here.
Okay.
Yeah, I mean, it depends in part on how severe your infection was, but we think most people have pretty good protection for at least 3 months, especially if you had a significantly symptomatic course. There's some concern that some of the variants, particularly the South African variant, the immunity isn't as good. So you might want to keep an eye on those variants in your area. We're not seeing a lot around here. I'm not sure about Arizona if they're seeing much in the way of the South African variant. But yes, probably pretty good protection. Doesn't mean you want to throw caution to the wind, but in terms of how urgent is it that you get vaccinated, or what your risks are in general, they're definitely significantly less. You should have pretty good protection for probably 3 months, and it doesn't fall off a cliff, but it starts to wane after that.
Yeah. So let's see. Debbie's saying, "What's your thought on Johnson & Johnson vaccine? 85% protection towards COVID and one shot."
Yeah, I'm excited about the Johnson & Johnson vaccine. It's very easy to use. It is one shot. It's probably a little bit less in the way in terms of the day after side effects that we see with the mRNA second vaccines, the Pfizer and Moderna vaccines. Yeah. So I think it definitely has a place. It is a little less effective in terms of symptomatic disease. We see a lot of percentages thrown out there about it's 60%, it's 80%. Most of the time we're talking about symptomatic disease, and it seems to be about 85% against most of the strains in symptomatic disease. But in terms of hospitalization and keeping you from being dead, it's almost 100%. So if we can get rid of that, that's really good. I think it's an especially good candidate for people who are needle phobic, really want that one needle, one shot. For people who've had COVID before and they're needing more of a booster than starting from scratch, I think the Johnson & Johnson's really good. Or for young and low risk people.
Let me ask you this: because I agree with you, Eric, that what I'm reading is it's 100% effective, at least so far, even in South Africa, where the variants about preventing death, and about 85% effective in terms of preventing severe illness, which is defined as needing oxygen,
right?
Hospitalization. So if you had the opportunity to get a J&J shot right now, or wait a month to get a Moderna or a Pfizer shot, what would your vote be?
Yeah, no question. Get the one that's in front of you. The risk is far more in waiting than the difference between the two. They are not significantly different. So yeah, I would get whichever one's in front of you, barring very unusual circumstances. You should talk with your doctor. You've had severe allergic reactions or that sort of stuff.
Yeah. Marianne's asking, what vaccine are we giving of the 3 available? Right now, we've been receiving Pfizer and/or Moderna. So that's the ones that we've been giving here at the hospital. It just depends on what we get from the health department. Is it a requirement to get the vaccine in the same county that you live in? My understanding is that's not the case.
Yeah, that's my understanding too.
In fact, I know it's not the case.
Yeah.
So I mentioned this last week. One second here, Moxie, and then we'll answer your question. But if you look at our website, and Matt may pull this up now, there's actually a website that the CDC endorses that is it Vaccine Finder? Yeah, there we go, .org. you can pop into that, and it'll kind of tell you where in your area there are some vaccines available. And I'm certain that some of those areas are not going to be just in your county. So what was Moxie's question again here? Do you know when we start vaccinating? The one we are registered for the vaccine. We're in our 70s. Both have health issues. When we get vaccination. So Moxie, here at the hospital, we are still working through that 65 plus group. Last I heard, we were in the 75 to 85 group. About 4,000 people still left 65 plus that need the vaccine. So it just kind of depends on, how many vaccines that we get. Like I mentioned, we're doing 400 vaccinations this Saturday. So I don't have a time frame. It's more and more promising, at least from the hospital's perspective, the number of vaccines that we're starting to get. And I would encourage you, Moxie, and you probably already have, but make sure you're on the link with the health department. Use this vaccinefinder.org website, because up in Rockford, they're doing some, the National Guard, some sort of vaccines throughout the state. The state's doing some stuff. My understanding, a lot of those are Johnson & Johnson vaccines that they're starting to give in those places. So I would explore those options if you're really wanting to wait. In terms of the 1B plus group, we are at, once again, we're at about 4,000 left on the 65 plus group. Once we've knocked those folks out and given them vaccine, then we will start on the 1B plus group. And right now, that group for our organization is about 14,000 people. If it's like the other group, I think we had 16,000 or so in the 65 plus, and I think we only had like maybe half of them that said they wanted the shot. So, ballpark, I'm guessing somewhere between 4,000 and 7,000 of people that are 1B plus are going to be interested, at least right away, of getting the shot from us. So as they're available, we're giving to them. And I will tell you that our group, you literally, most of the time we get these vaccines in, it's within a day or two that these shots are being given. So our folks are really working hard. When we get it, we get it to patients.
Yeah, we really prepared for that, even all the way back to our influenza vaccine drive, and we did it all in one fell swoop so we could prepare to do this well, and been really proud of the coordination and the effort that's been made to make that happen. But we can only give what we have. Fortunately, that's improving. There's other ways to find it through pharmacies, but that's a little bit like trying to find a PlayStation 5 on Christmas Eve. You got to find out when the shipments are coming in. And
I like that.
For Walgreens, you get in, you log in at 6 o'clock in the morning, and then they go for CV or Hy-Vee. It's midnight, and so it's that vaccine finder is helpful though.
Yeah, good. So I appreciate the questions from those who are listening. Keep them coming. But for now, I'm going to ask another one that I have on my list for Dr. Coons. What have we learned about treating COVID in the past year, Eric, both on the clinic outpatient side as well as in the hospital?
Yeah, boy, that's a big topic. So I'm going to try and keep it to a couple of highlights.
Sure, I understand.
Things. Yeah. First, while we've had a lot of incremental advances on the inpatient side, when COVID gets bad, in other words, people come in a lot of trouble already really short of breath, far into the disease, it's still very hard to treat. We don't really have a silver bullet for those people. We've gotten a lot better about incremental advances, but it's not unusual to still have patients in the hospital for weeks to a month or more. So that part is still very tough. It's better, but it's still tough. We really got to make sure we focus on early treatment and prevention, especially of high-risk people. And moving to the outpatient side, that's where I think we've seen probably the single biggest advance is my new favorite term, bamlanivimab, which is the antibody. What's that?
Well done.
Yeah, I've been practicing that a little bit. Anyway, it's the antibody cocktail, and there's a couple others that are coming too. That if you're a high-risk person, and high risk isn't that hard to meet. If you're a little overweight, high blood pressure, high cholesterol, any of those sort of things, you may well fall into that. But if you're a high risk person and you get it within the first 10 days, which means we have it flowing into your arm in the first 10 days, then it seems to decrease hospitalizations by about 70%. And that's the biggest number that we've been able to accomplish as far as, everybody's looking for a magic bullet all the way back in the days of hydroxychloroquine. This is as close as we've come to that, I think, for the right group of people. Now, for low-risk people who are minimally symptomatic, probably not that helpful. But for people who are high risk, so if you get a positive test or you think you have symptoms and you're getting tested, talk to your doctor, because we've got to get you plugged into that system early. So I think that's the biggest incremental thing. There's a lot of questions still out there about other things that may contribute. But boy, it takes a while to get big studies done. For things like vaccines where we're giving 80 million doses, data accumulates very quickly. For stuff that we're trying to figure out whether it works a little better than standard care, that stuff takes a long time, and we're still working through some of that.
Yeah. From the inpatient side, it seems like if there were something, it's that we've went from don't give this to okay. It seems to help some is this dexamethasone or steroids.
Yes, yeah, that is the biggest single different drug change that way. And early on we were worried about increasing viral replication, but what we've learned with this disease is there's a big difference between the first phase of COVID and kind of the second inflammatory phase. And once you're in the second phase, steroids are very helpful at that point. They may still be problematic maybe early on, but at the right time, they're very helpful. And getting more comfortable with people being a little thicker, having lower oxygen levels before we intubate them is another different change, I think.
Yeah, that's true. Yeah.
That we've this disease is different, and we're not quite as aggressive with that, and that seems to be paradoxically helpful here.
Yeah. I'm going to shift gears a little bit and go to a question about just what the future looks like. And I'm going to start by just throwing out this question to you. Do you think, number one, do you think COVID will ever go away? And if not, what is a realistic new normal with this virus that allows us to live our pre-pandemic lives, Eric?
Yeah. So with a 95% or close vaccine, is it possible we could get it to go away? Other vaccines that have been really effective like that have really made things go away or almost go away if they're used really well. Things like polio and measles, to the point they're used really well. So maybe if we got the whole world vaccinated pretty robustly, I think more realistically, and what I would hope for is that this kind of fades into the background, like West Nile virus, for example, right? It's still out there, it's still around. We still have to think about it from time to time, but it's not really in the forefront of what we think about or what we do. We don't deal with it all the time medically. So my hope, and I think it's pretty reasonable that we'll get there, that this fades into the background with things like that. Maybe we get a booster shot every now and then, more like tetanus or a Tdap.
Yeah.
I don't think we're going to have to be facing this like we do influenza, because influenza is a very different bug and very uniquely good at shape shifting and making it very difficult to keep track of. And fortunately, COVID is a much better target for vaccines that way.
Yeah. I've heard the word endemic rather than pandemic, which is just that it's there, but it's not at a level that is as high as it is right now. Like we take on the risk every flu season. In the last 10 years, I was reading between 12 and 60,000 people died from influenza in the U.S. every year, and average is about 25. 30.
Yeah.
And we know that, we live with that. And COVID so far this year has unfortunately killed, I think 510,000 people. So that's a huge difference. If we get to the flu level and of an endemic type of situation, okay.
Yeah. We've never had a vaccine for flu that's been anywhere near the effectiveness of the vaccines we have now. So I think it's very realistic that we can make this better than influenza. And I'm pretty sure we'd get down to that level. So I think as far as getting back to normal lives, everybody's speculating on this, right? And who knows for sure, but I think by the time we get to summer and we have, the federal projections are now that we'll have vaccines for most everybody by the end of May. Boy, that's pretty exciting, because that means between being outside more, having everybody vaccinated, and just the time of year that makes it better, that we'll be reasonably normal by midsummer, I would think. Which I mean, that's like huge, right? That's
Oh, yeah.
really exciting, and to have the ability to look forward to that from what's possible, mostly through vaccination, really, is great.
You said a key word there, and that's where it's going to be interesting as we have an inflection point and have more vaccine than we have people that want to get it.
Right.
Everybody vaccinated.
Right.
That's an interesting variable about how soon we get back to normal. Some of that will depend upon us making individual decisions.
Yeah, the vaccine is very capable of getting us there, even with the variants. It's more a matter of whether we'll be on well enough on board with that. And don't get me wrong, I understand where the concern comes from. There's a lot of this that's new, new things. Medically speaking, we're always a little concerned about. Although I will say I'm more concerned about new medications as far as the long-term effects, things you take every day. They build up a level, they have interactions. The things that we give one time, we get those results, especially when we're giving it to so many people, much quicker. So while I understand where the concern and reticence comes from, very much so, I mean, I think we were all waiting for this data to know whether it was really going to be safe or not. And maybe I'm getting a little ahead of things, but 80 million doses in, and even our 1,100 people in the hospital, the great results we've had with that, we're pretty comfortable that this is safe, certainly safer than taking the risks of COVID. I've already had patients that early on decided they were going to wait on vaccination when it was offered to them, healthcare providers, that have ended up in the hospital, and some of them with really bad outcomes. And so anyway, I'm excited about what's possible here.
Yeah, I'm with you. So, and you mentioned our employees, 1,100 or so have had it. And I was just checked again today. None of them have had a symptomatic infection with COVID.
Wow.
Vaccinated.
And I know that's not the case with all of our employees who decided to wait.
Of which there's only 400 or so that didn't, 400 or 500 that didn't get it. So if it's just very clear that the vaccine is very effective.
Yeah.
Yeah. What was the question? If you have an antibody test and have them, how long are you safe for? And do you think it's a good idea to get one if you're under 16 so you can participate in things without being quarantined? Want to take a crack at this one, Dr. Coons?
Yeah. So, boy, an antibody test, there's a few problems with that. One, it only tells you if you have some antibodies, not a lot or a little. It doesn't give you an amount. So, and then there's also, it's a little bit less accurate of a test still as far as other things. It's gotten better, but early on, especially, a lot of these antibody tests were being pushed out that could detect coronaviruses that were non-COVID and things like that. I think that's gotten better, but I don't know that I would be comfortable saying you're good. You don't have to quarantine. You don't have to take precautions, especially because we don't know what level of antibodies that you have. And it may not be enough to be really protective. So if you're 16 and up, you can get when it comes your way, you can get vaccination, and that we're pretty comfortable with. But antibody tests.
So you're not. I'm hearing from you, Eric. You're not comfortable with using an antibody test to make a decision about whether you're immune or not.
No. Yeah.
Okay. All right. Let's see. Yes. Are we still waiting as far as safe to be in small gatherings like one-on-one with family in my home if all are vaccinated? I'm not sure if this was addressed already.
Boy, lots of familiar faces. Hi, Julie. She's a good friend. So as far as being okay to be in small groups, if everybody in that group is vaccinated, I think the risk gets pretty low. And I think even Dr. Fauci, as conservative as he is, he did mention that small groups is probably, and I'm talking about small, probably one hand, definitely not more than two hands for sure. And I hope I'm not going out on too much of a limb here, but for that to go bad, if everybody in that group is vaccinated, you have to have the vaccine fail the index person, which is, we know, 95% of the time that doesn't happen, at least at a rate of symptomatic disease. We know in the people who it does fail for, based on good data out of Israel, that the viral loads are only about a quarter of the viral load of people who test positive without the vaccine on board. So that amount of viral load still has to be enough to be infectious, which is not very likely. And the vaccine has to fail the person that would be getting it. Having all of those things happen together seems pretty unlikely. And, in medicine, we're always a little hesitant to say you're good, but I also think we have to be respectful of, we need to have some of those interactions happen. We've been working really hard for a year trying to keep people safe, and so I think small groups, if everybody's vaccinated, is reasonable.
And I might add to that, Eric. And if they're not vaccinated and it's a small group, some sort of agreement about how you're going to go about living your life for a week or so before you get together.
Yeah.
So that you have some sort of bubble is the word that you hear, but some sort of expectation of, I'm not walking around, I'm not eating lunch with my colleagues with my mask off really close to them. I'm wearing a mask everywhere I'm at. Those type of things. It all, it's all risk mitigation, and those activities between a vaccine and or being very careful before you get together can be very helpful.
Yeah, doing stuff outdoors, all the stuff we know helps. Outdoors is really a big deal. That's one of the silver linings of this is a lot of people rediscover the outdoors, right? There's kayak sales and bike sales are through the roof, and I hope we don't lose that, because that's been good. And so going out, if you want to go out with a group and go on a hike, fantastic. Have an outdoor picnic. Not too much risk there.
Yeah. If you look at speaking of, so I'm gonna one last question before I get, because I don't want to take too much of your time, Eric. But if you look the backside of Dr. Coons' door there, you would see, speaking of outside stuff, his exercise goals for this upcoming year that he put up there for his staff to see. Have your staff put anything up yet, Eric?
I have not gotten them to come in yet, but I will.
One of the things, if I remember right, was some type of kayak triathlon kind of thing.
Yeah. So I'd like to do a triathlon, but I'm not a great swimmer. So they have ones that have kayaks in them, and I think I would like to at least try one of those. I want to go 100 miles on the bike this year, and I want to get 21 miles in on the bike. Those are my goals for this year. So now that I put it out in front of the entire world, I guess I'm committed, right?
We'll have you back in about sometime in October, November, and find out how things went. Maybe.
All right.
Yeah, let's see. Are you still treating people with plasma transfers with good results? News on this recently, we did
just talk about this. We are not treating very many people with plasma transfers at this point. It hasn't worked out as well as we had hoped. The bamlanivimab seems to be more effective for the situations that it's applicable to. There is some thought that in a certain time frame, if we get the right type of plasma, it might still be useful, but it's definitely become more of a niche thing than something we're doing for the general COVID patient.
I think I read yesterday where NIH pulled a study they were doing on that.
I didn't see that one, but
I just don't think it just hasn't panned out.
Hasn't
panned out like we thought it might. So here's my last question for you. So as you've been reflecting, we were talking a little bit here, and I know you've been thinking about this whole year about all this, but what do you see yourself doing differently personally and professionally as a result of this pandemic?
Yeah, it's It's made, boy, there's a lot to that question, but it certainly made me much more reflective about all the things we take for granted, for sure. So I'm when we get together with people, I'm really going to enjoy that some more and be more mindful of that. I am also impressed with the degree that we can change regular infectious disease to a much greater degree than I think we knew was possible with influenza, pneumonia. I mean, as much as COVID has been very hard, especially in those spurts where it got really bad,
Yeah.
the rest of the year, there have been times that have been fairly quiet in the hospitals sometimes between that because we're not seeing as much of those things. And so being more aware of the little things we can do to make that better, for sure. And yeah, that's most of it, I think.
Yeah, good. Well, hey, Dr. Coons, thank you so much for taking the time to join us and share your perspective on the pandemic, and appreciate your leadership in the past year with the stuff that's been going on. I know there's people don't know behind the scenes how much stuff work that you put in to help here at the hospital with our medical staff. So thank you for that.
Thanks.
Yeah, good to have you today, and well, we'll have you again. So
all right. Yeah, looking
thank
forward
you
to
very
it.
much, everybody, for listening and watching, and take care, and we'll talk to you next week. Thank you.